بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the last lecture in the topic of the venous imaging or imaging of the venous system. And we have finished with the imaging of the portal circulation, and also we finished the imaging of the intracranial venous system. Then we are going to handle this topic about the peripheral veins as well as the superior vena cava and the inferior vena cava. There are a lot of lesions that can involve this system when we will deal with the most common of these pathologies, including the anatomy of the superior vena cava, causes of superior vena cava obstruction. Then we'll deal with the IVC, and we'll finish with the deep venous thrombosis of the peripheral veins, and what do we mean by post-thrombotic syndrome. And finally, we will have some words about the Klippel-Trenaunay syndrome. Actually, before the era of CT and MRI, we used to see the venous system through injection of contrast material in the veins, and this is one of the ways that we use to show the superior vena cava. We inject contrast material in the limbs. Then we simultaneously injected this contrast material, as you can see here, from the left and right upper limb, so that the concentration of the contrast material will appear concentrated in the superior vena cava, so that we can diagnose any abnormality or the presence of obstruction. But later on, after the availability of CT and MRI, we can easily see the superior vena cava through these techniques. This is one of the images using the old technique by injecting contrast material through a cannula placed on the dorsum of the hand and on the left side and also on the right side, with simultaneous injection of contrast material. And here, this is the region of the superior vena cava, and you cannot see the superior vena cava itself because of the presence of this mass, which was considered the most common cause of superior vena cava obstruction at that time. Then here are the causes for superior vena cava obstruction, including malignancy, especially the bronchogenic carcinoma and lymphoma. Also, recently, the central venous catheters are one of the well-known causes of superior vena cava obstruction. The placement of wires and this disease also, which is known as fibrosing mediastinitis, also Behçet disease. Behçet is one of the diseases that cause vena cava obstructions as well as pulmonary aneurysms. Then the clinical presentation of a patient with superior vena cava obstruction may include the presence of facial and neck swelling, also facial flushing, upper limb swelling on both sides, and some neurological signs, and maybe dyspnea, headache, and cough. And what are the imaging appearances for a superior vena cava obstruction? The plain X-ray, you may see mediastinal widening or superior mediastinal widening, and also you may got enlargement of the right hilar shadow. which may be the sequelae of the presence of a mediastinal mass or a bronchogenic tumor. If you have the cross-imaging techniques, you can see a filling defect within the superior vena cava, like this one. You may also identify the mass, which is responsible for obstruction, and meanwhile, you can see multiple dilated collateral vessels in the chest wall secondary to this obstruction. Then this is a case of bronchogenic carcinoma, the central type that has invaded the mediastinum and also invaded the superior vena cava. You know from the anatomy, and the superior vena cava is present here, and this is the ascending aorta and left pulmonary artery and the ascending aorta. There is a big mass infiltrating the region of the superior vena cava as well as the precarinal area, and you can appreciate that the mass is encasing the right main pulmonary artery together with the presence of a significant pleural effusion on the same side. Then at the time we have to discriminate between the thrombus inside the superior vena cava, whether it is a regular thrombus or bland thrombus, or it is a tumor thrombus. There are many ways to differentiate between the tumor thrombus and the uh, uh, bland or regular thrombosis. One of the ways is that the tumor thrombus will expand the vein or the vena cava. The tumor thrombus will enhance with contrast material, and also it will show metabolic activity on the metabolic imaging techniques. And this is a tumor thrombus. You see that the superior vena cava is enlarged, and you can appreciate contrast enhancement within the mass occupying the superior vena cava, and you can appreciate the dilated veins secondary to superior vena caval obstruction. And this is a case known to have metastatic esophageal cancer with a filling defect within the superior vena cava denoting thrombosis extending into the right internal jugular vein. And you can see this mediastinal metastatic lymph nodes and also the presence of pleural effusion. This thrombus is not a malignant one because it does not enhance, it does not expand in the vena cava, and the thrombosis here could be due to the hypercoagulable state, which may be present in patients having malignancies. And this is a case of superior vena cava obstruction secondary to repeated central venous catheter placement. And this is nowadays one of the well-known causes of vena cava obstruction. The presence of multiple central venous lines will lead to the introduction of infection to the superior vena cava, which may result in thrombosis later on. Then you cannot identify the superior vena cava at its anatomical site. And instead, you can see these multiple collateral venous channels within the superior mediastinum. And the catheters are known in patients with renal failure for hemodialysis, and this is a case of end-stage renal disease with multiple central catheters used for hemodialysis resulted in total occlusion of the superior vena cava and multiple markedly dilated collateral venous channels in the mediastinum. One of the ways to resolve the superior vena cava obstruction or due to thrombosis or due to venous catheter placement is to introduce a stent within the superior vena cava to maintain the lumen of the vein patent. And fibrosing mediastinitis is a non-malignant mediastinal acellular collagen and fibrous tissue proliferation. This is not a neoplasm, and the underlying etiology in many cases is not well known, but this disease may appear in the focal type, which may simulate malignancies in about 80% of cases and may be diffuse in about 20% of cases. Typically, this disease affects young adults but can also seen in different ages. Then the possible underlying causes for fibrosing mediastinitis. In many cases, you cannot see a definite underlying cause, but TB, sarcoid, intrathoracic malignancies, radiation, and histoplasma capsulatum infection are some of the underlying causes that may lead to superior vena cava obstruction. They may lead to fibrosing mediastinitis. Then Uh, what are the imaging findings in patients with fibrosing mediastinitis? The X-ray may show widening of the superior mediastinum due to the presence of this mass of fibrous tissue. Also, you may see a hilar or mediastinal mass on the plain X-ray, but on the CT scan and one of the prominent features of this fibrosing mediastinitis is the presence of calcium in this mass, and also if you inject contrast material, the mass will enhance heterogeneously with contrast medium. In here you can see a mass which is located in the precarinal and subcarinal area, and this mass is heterogeneously enhanced and heterogeneously calcified. This mass may encroach on the bronchial lumen and also on the vascular lumen, as you can see here. This big soft tissue mass with dense central calcification seen in the subcarinal area, encasing or compromising the lumen of the right pulmonary artery, which is reflected on the perfusion scan. You can see this lung is not well perfused compared to the left side, and also it will affect the bronchial lumen as well. In the chest X-ray, you may appreciate the presence of some sort of mediastinal widening or hilar mass, but CT is one of the good modalities to delineate this pathology. Then we came to the problems of the IVC, and now we can see the IVC by the old technique similar to the superior vena cava. We inject contrast material in the femoral vein bilaterally to pacify the IVC. But now we can use the CT scan and also the MRI. In the CT scan, we inject the contrast material and we image the region of the IVC in the venous phase, and we can delineate the inferior vena cava as well as the renal vein, and we can go through up to the right atrium. It is important to identify if this IVC is absent or if it is duplicated. In cases of duplication, we should care about the issue of filter placement, so that if the patient had deep vein thrombosis and he has also double IVC, and the filter should be placed on both IVC channels. Then if double IVC is not recognized and we place the filter in one of them, then recurrent pulmonary embolism can develop. Remember that tumor thrombus will expand the vein. The tumor thrombus will show contrast enhancement and metabolic activity, and this can differentiate the tumor thrombus from the bland thrombus. Congenital anomalies of the inferior vena cava may appear in about 4% of the population. Most of them are asymptomatic, and these anomalies may include the presence of IVC webs like this, or sometimes a segment of fibrotic occlusion that may have a variable length. This web will prevent the venous drainage from the liver to the heart and may result in dilated intrahepatic and extrahepatic venous collaterals and may lead to what is similar to Budd-Chiari syndrome, which may precipitate for the development of hepatocellular carcinoma later on. And we should have some words about the azygous venous system, which is the system provides alternative venous drainage from the limbs if the IVC is not or if the IVC is obstructed. And we have the azygous vein or the hemiazygous, the accessory hemiazygous, and the left superior intercostal vein. The azygous vein is made mainly by the right ascending lumbar vein as well as some of the intercostal veins and the right subcostal vein. This big vein will ascend alongside the aorta and it goes through the diaphragmatic hiatus until it joins the superior vena cava. The hemiazygos is made mainly by the left ascending lumbar vein and some of the intercostals. It will join the azygos system at the level of the eighth dorsal vertebra. The left the hemiazygos at the accessory hemiazygos vein drains some of the upper limb area, as I will mention later on. And this is the azygous vein, which results from the union of the right lumbar vein and the right subcostal vein at the level of D12. Then it enters the thorax through diaphragmatic hiatus and it joins the superior vena cava approximately at the level of the dorsal vertebra number 5. This vein drains the lower 8 right posterior intercostal, some of the bronchial and the right superior intercostal veins. The hemiazygous vein is made mainly by the left ascending lumbar vein and it drains the 9th to the 11th left posterior intercostal veins and it joins the azygous vein at the level of the dorsal vertebra number 8. The accessory hemiazygous vein drains the superior left hemithorax. It arises from the 4th to the 8th left posterior intercostal veins and it also drains the left bronchial vein and some of the esophageal veins. It joins the azygous vein at the level of the dorsal vertebra number 7. And this is the appearance of the azygous vein joining the superior vena cava in serial images taken for the thorax. One of the common findings is the anomalous continuation of the IVC. Sometimes the azygous vein helps as a continuation to the inferior vena cava, especially if it is interrupted, usually in the region of the liver. Then, if you look carefully here, and you can see the aorta, but you cannot see the IVC. And in the cephalic sections, you see the aorta and the big vein, which is adjacent to the aorta in the retrocrural area, and this is the azygous vein. If you go to the thorax, and then you see the azygous vein, which is markedly dilated, going to the superior vena cava. Then if you look here and you can see that the aorta with the azygous vein to the right, if you see the vein to the left of the aorta, and this will be the hemiazygous. If you see the vein to the right of the aorta, and this will be the azygous itself. and the upper part of the superior vena cava is present, and it drains the blood from the liver to the right atrium directly. And this azygos vein helps as a continuation of the IVC, and you can see the markedly dilated azygos vein going to the superior vena cava. And duplication of the IVC is an important finding, especially when a filter placement is considered in patients with deep vein thrombosis to prevent pulmonary embolism. The original IVC is located at its normal side along the right side of the aorta. The other IVC will classically present to the left of the aorta, and it will drain into the left renal vein, which consequently will drive the blood supply to the original IVC. And here you see the aorta, and you have two veins alongside the aorta, and these are double or duplicated inferior vena cava. And here is a good example. You see this is the left-sided IVC draining into the left renal vein, which will go to the original IVC, which is located to the right side of the aorta. Then there may be a left-sided IVC only, and this left-sided IVC will classically drain the blood to the left renal vein, which will cross the midline to join the remaining part of the aorta along the original course of the IVC to the right side of the aorta, continuing to the right atrium. And this is the common iliac veins draining into the IVC, which is located to the left side of the aorta. And this left-sided IVC will cross the midline to join the to continue along the normal course of the IVC. Some of the anomalies which may affect the urinary tract, and this is what we call the retrocaval ureter or the circumcaval ureter many times. In the IVC, and you can see that there is some blood pressure changes, especially on the right side, and you cannot see an obstructive lesion. In this case, the ureter may have an abnormal course posterior to the inferior vena cava. And you can see here, this is the aorta, and this is the IVC, and this is the ureter, which is now posterior to the IVC. And in this section, it is along its medial aspect, and here it is along the anterior aspect. This is what we call the circumcaval ureter, and this is one of the causes of some blood pressure changes on the right side. This is also a circumaortic renal vein. In this section, you see the renal vein is posterior to the aorta, while in this section, you see the renal vein is anterior to the aorta, and this is what we call a circumaortic renal vein, and you can appreciate this anomaly by the reformatted images. And this is one of the famous anomalies of the renal vein, which is located posterior to the aorta, what you call retroaortic renal vein. And this is one of the important findings to be reported in patients going to donate the kidney. We should identify the number of the renal arteries on both sides, and also we should identify the course of the left renal vein, whether it is posterior to the aorta or anterior to the aorta. And this is also a retroaortic left renal vein. This is the aorta, and the renal vein is crossing behind the aorta. And the tumors of the IVC, the well-known tumor is the leiomyosarcoma, which is considered an extremely rare malignancy, and it represents less than 1% of all malignancies. But leiomyosarcoma accounts for more than 75% of large vein tumors, and 75% of IVC leiomyosarcoma occur in women between the age of 40 to 60 years. Then How can you differentiate the tumor thrombus from the planned thrombus or the regular thrombus? And this is one of the important issues. You remember that I have mentioned that the tumor thrombus will expand the vein, the tumor thrombus will enhance with contrast material, the tumor thrombus will show metabolic activity, and um, and this is the a tumor thrombus affecting the most of the IVC. This are the incidence of the involvement of the IVC by leiomyosarcoma, renal and suprarenal in about 45%, intrahepatic in about 15%, infrarenal in about 40%. And the renal and suprarenal involvement has the most favorable prognosis according to the literature. And here you see this is an inferior vena cavography performed by the traditional way. This is part of the inferior vena cava, and the upper part is occluded with collateral circulation. And here by CT scan you see the aorta, and you see a mass infiltrating the region of the IVC representing leiomyosarcoma. Another case of leiomyosarcoma of the inferior vena cava. Here is a big mass which is heterogeneously enhancing. And one of the ways to treat this is by resection of this part of the IVC and putting a graft to ensure the venous drainage. Then the overall survival is about 14%, and more than 50% of the patient will develop recurrence of the disease. Then secondary involvement of the IVC by neoplasms of the adjacent organs is more common than the primary malignancies of the IVC. And one of the common lesions that can extend to the IVC is the renal cell carcinoma, which is the most common malignancy to involve the inferior vena cava. 4 to 10% of the renal cell carcinoma will involve or can involve the venous system, including the renal vein to start with, then the IVC, then going to the right atrium. Then one of the findings that can support the tumor invasion rather than planned thrombus. In number one, you see the tumor mass in the kidney, and number two, the tumor thrombus will appear on MRI in T1 and T2 weighted images having the same signal characteristics of the renal mass. While the planned thrombus will appear of bright signal in the T1 and T2 weighted images due to the presence of methemoglobin. Here, a big mass in the left kidney going through the left renal vein, reaching the IVC, and there is in the coronal image, you can see the extent of the tumor, and also here you can see inferior extension along the ovarian vein, which, as you know, this ovarian vein drains into the left renal vein. And consequently, the tumor has invaded the left renal vein together with the ovarian vein. Then adrenocortical carcinoma is the rare malignancy but can also invade the IVC. Of course, the right side tumor is very close to the IVC compared to the left side one, but there is an incidence that the tumor can go to the IVC. It's a bilateral adrenocortical carcinoma, and there is obliteration of the inferior vena cava by thrombus, which is similar in density to the original tumor. And also, this is a case, the same case of adrenocortical carcinoma. And you remember, this carcinoma can be bilateral, can occur in the pediatric age group, as I have mentioned before. And here is the IVC, which is infiltrated by the tumor. Also, Wilms tumor, being a renal malignancy in the pediatric age group, can extend into the renal vein. Then one of the lesions affecting the IVC is the aortocaval fistula, the developing of a communication between the aorta and the IVC. And there are two main causes. The commonest one is the aortic aneurysm, eroding the wall of the IVC, then resulting in direct communication. And the less common cause is the trauma. And this fistula will result in acute symptoms due to the high flow congestive heart failure. 85% are due to the aneurysm and 15% are due to the trauma. And there are a few cases of neoplastic and inflammatory lesions also. One of the main findings in the upper abdominal sections is to see that the aorta and the IVC are simultaneously opacified in the arterial phase. This means that there is a direct communication between both vessels, and this will appear lower down in the abdomen. And here you see that the aorta and the IVC are simultaneously opacified lower down. You see the aneurysm of the aorta that has eroded through the wall of the IVC, resulting in this communication. And I have mentioned in the lecture of portal venous system, if you look to the segment of the IVC in the liver, and you see that this segment is simultaneously opacified with the aorta in the arterial phase, then you think of passive hepatic congestion due to cardiac problems. But lower down in the abdomen in the retroperitoneal area here, if you see simultaneous opacification of the aorta and the IVC, think of the presence of this fistulous communication lower down. And here you can see an example, the aorta and the IVC has been delineated by contrast material in the same time. There are one of two possibilities. Either this is passive hepatic congestion, but you cannot see that the hepatic veins are not dilated. In passive hepatic congestion, the hepatic veins are also dilated. But here you can see lower down the aneurysm in the aorta, and this is the fistulous communication between the patent lumen of the aneurysm and the IVC. Then thrombosis of the IVC has many underlying etiologies, including the hypercoagulable state, malignancies, venous stasis, focal compression, filters, bland thrombus extending from the lower veins. And like the tumor thrombus, bland thrombus do not expand the vein, and bland thrombus do not enhance. And you see here, this is the aorta, and this is the IVC, this is the portal vein. The IVC is obliterated by the thrombus. And here you see the whole course of the inferior vena cava is obliterated by a hypodense non-enhancing thrombus. Another example of inferior vena cava thrombosis, extensive inferior vena cava thrombosis, you see the lumen is not expanding and the thrombus is not enhancing. Sometimes you can see this, which is the calcification of a thrombus present in the inferior vena cava, and this may see primarily in children. IVC calcification in adults is extremely rare according to the literature, and the potential causes include abdominal malignancies, adrenal hemorrhage, coagulopathy, and infection. This is one of the examples in an adult female patient with calcification inside the IVC, and this is due to the presence of thrombus here. Then IVC filter is one of the techniques commonly used in patients with deep vein thrombosis with a risk to develop pulmonary embolism. And we put the filter in the IVC to prevent the emboli coming from the lower limbs to reach the pulmonary artery. And the indications include in patients with this deep vein thrombosis, if they have contraindication to anticoagulant, like if they have an active gastrointestinal bleeding or they have a recent neurosurgery or even cardiosurgery. And pulmonary embolism, despite of the use of anticoagulant, patients with deep vein thrombosis develop pulmonary embolism in spite of being on anticoagulant therapy. Poor patient compliance with anticoagulant treatment and large ileocaval floating IVC thrombus, and this is a good indication for placement of the filter. And this is the appearance of the filter after being placed in the IVC, and we inject contrast material to see that the filter is well positioned at its site. Contraindications for the use of the filter is the presence of vena cava thrombosis, or that the inferior vena cava is too small or too large to admit a filter safely. Then the presence of septic thromboembolism is also one of the contraindications. And here is the appearance of the filter by CT. See the limbs of the filter and the umbrella. These are the complications of IVC filters: bleeding, filter migration, vena cava injury, vena cava thrombosis. Pulmonary embolism may occur despite of the filter presence. Then we came finally to the imaging of the lower veins and the lower limb veins. We have the ascending venogram, the descending venogram, Doppler ultrasound, CT venography, and MR venography. This is the old technique we use to show the lower limb veins by ascending venogram. We put a cannula in one of the veins on the dorsum of the foot, and we place a tourniquet above the ankle and another tourniquet below the knee to prevent the contrast material going to the superficial venous system. We work that the contrast material is only located in the deep venous system. And if there are perforators, we can delineate these perforators providing the blood supply or shifting the blood supply from the deep to the superficial venous system. And you know that we have three arteries here: the anterior, the perineal and anterior tibial and posterior tibial. Each artery has two veins running along each side, and then we have three groups of paired veins corresponding to the anterior tibial, posterior tibial, and the perineal arteries. All these veins have competent valves that prevent the blood supply from going back in the opposite direction. And here is the popliteal vein, and this is the femoral vein going to the external iliac. And after passing to the adductor canal, it becomes the femoral vein, and the femoral vein will join the deep femoral vein, which corresponds to the profunda femoral artery, to form the common femoral vein. Then there is no superficial femoral and deep femoral veins. The superficial femoral vein is the saphenous vein, and the femoral vein is the original one, and this is the deep femoral vein which corresponds to the profunda femoris artery. And descending venography is retrograde one. We put a cannula in the common femoral vein, and we inject contrast while the patient is performing Valsalva maneuver, and the second film is taken while the patient is taking deep breath. Then if the valves are competent, then the descent of contrast material should not be more than 2 to 3 centimeters below the level of the inguinal ligament. But if the valves are incompetent, you can see easily the passage of contrast across the vein, as you can see here. With incompetent valves, if you inject contrast material, and you can see that the contrast material is going down across the vein. Then CT venography is performed by injecting the contrast material either in the antecubital vein or in the dorsum of the foot. Uh, uh, we inject both sides to see the both limbs if it is indicated. But commonly, this technique is performed while doing CT pulmonary angiography to assess the presence of pulmonary embolism. Then, after injecting the contrast material and having the CT pulmonary angiography, we can go rapidly to image the lower limbs by the same contrast material injected in the antecubital vein. And you see here in the thrombosis in the popliteal vein, and this is the normal side. The popliteal artery and the popliteal veins are patent, and here you see the filling defect. And you may reconstruct the images along the whole course of the limb, and you can see extensive deep vein thrombosis on the left side appearing as a filling defect across the whole lower limb. And here is the thrombosis of the left common iliac vein extending into the lower part of the IVC. The right common iliac vein is patent. MR venogram is performed, as you can see here, by putting tourniquets at the ankle and about the knee joint. We put a cannula in one of the veins on the dorsum of the foot on both sides. We inject gadolinium, and then we can image the lower limbs. We can use the contrast material to show both arteries and veins. Then we subtract the images, and you can see the arterial tree, and you can also see the venous tree. The same way we interpreted the images of conventional venogram, we interpret the images of MR venography. Here you can see patent normal veins, and here you see multiple dilated varicosities due to the presence of venous insufficiency. Patients with deep vein thrombosis may present by lower limb edema, and this is one of the common symptoms. Leg pain in patient is not specific, it has many causes. Tenderness, warmth, and the erythema of the skin over the area of thrombosis, and may also have the clinical symptoms of pulmonary embolism like the presence of chest pain and hemoptysis. 50% of patients with classic symptoms have negative venogram, and the 50% of patients with venous thrombosis lack specific symptoms, meaning that in many cases whenever there is a suspicion, then you should go for imaging. Here are the underlying causes of deep vein thrombosis, and they are too many, including the immobilization, hospitalization, surgery, cancer, trauma, obesity, and the smoking, of course, hypercoagulable state, and genetic predisposition, medications like contraceptive pills, and so on. And this is the conventional venogram showing multiple filling defects within the leg and thigh veins, diagnostic of acute venous thrombosis. And these are in the era of venography, we used to put some of the signs for venous thrombosis like luminal filling defect, the tram track sign, and you see the enhancement, or sorry, the contrast material along both sides of the thrombus upfront, the venous occlusion like the arterial occlusion, and formation of the meniscus sign. If you see here, and you can imagine this sign, for example. And this is the case also by conventional venography. The worm-like filling defect, extensive thrombosis of the venous system. After the sometime they got the what we call the post-thrombotic manifestations, which will result in irregularity of the vein itself and residual filling defects, and of course destruction of most of the valves in the involved area. The complications of deep vein thrombosis is, of course, the development of paradoxical emboli, and they present the development of pulmonary embolism and the recurrence of symptoms. And this is an important issue, which is the development of post-thrombotic manifestations, or what we call post-thrombotic syndrome. This syndrome involves the presence of signs and symptoms of chronic venous insufficiency following deep vein thrombosis. And this, as I have mentioned, the venous thrombosis will result in destruction of the valves and valve incompetence. Then you got venous hypertension due to thrombotic occlusion, and this stasis due to destruction of the valves. This will result in this combination of symptoms, including pain and edema, varicose veins, skin pigmentation, and these venous ulcerations, which are very resistant to treatment, and they need usually excision and the grafting of the area that developed ulceration. And in cases of deep venous thrombosis after treatment, and you got the post-thrombotic manifestations, which include irregular luminal filling defects, like these filling defects, for example, destruction of the valve system, and multiple incompetent perforators driving the blood supply to the superficial veins, resulting in opacification of many of the superficial veins. All these symptoms are included under the title of post-thrombotic changes. Finally, the Klippel-Trenaunay syndrome is a triad of port wine nevus, like this one, bone and soft tissue hypertrophy of the limb, and you compare this limb to the opposite one. This is referred to as localized gigantism. Then varicose veins and venous malformations of unusual distribution. The prevalence of this disease is like 1 every 100,000 population. Patients usually present in infancy and may be diagnosed in utero. Features are often unilateral and typically affect one limb, but sometimes you can see minor changes in the opposite limb. And the plain film will show elongation of the bone, soft tissue thickening, and multiple calcified fibroblasts. The MRI and the CT venogram, for example, they show, when you compare these two limbs, the left one is swollen, and you got many dilated tortuous venous and the lymphatic channels, together with the thickening of the subcutaneous tissue and the obliteration and the stranding of the subcutaneous fat. And this is one of the cases that you can see the main front of the disease is on the left side, but you can also appreciate minor changes in the right side. And here is a CT scan of a patient with right-sided Klippel-Trenaunay. There is an overall increase in the thickness of the limb itself, and these venous and the lymphatic channels, and also you got the skin thickening with obliteration of the subcutaneous fat. Thank you very much. Alhamdulillahi Rabbil Alameen.